First question here, are SSRI/antidepressant medications harmful to NET patients? Do they exacerbate carcinoid syndrome? Okay, so when you look at a drug class as SSRIs, Big Pharma is not interested in testing SSRIs in carcinoid syndrome patients. There is absolutely zero, in fact, it's probably below zero interest. Why is that? Because it's only potential disaster for them. They're not interested in the chemistry, they're only interested in potentially selling a product. They don't see carcinoid syndrome as an area that they want to go into. So how do we get data on this? Well, the Canadians have done the best evaluation of this question. Canada's system of medical care is a bit different. They can look in their database and see these patients who have had SSRIs, and a couple of years ago at our professional society, North American Neuroconsumer Society, when we met in Seattle, there's a Canadian that came down and published, well, presented, and I suspect hopefully they've published, their experience with SSRIs. And what our Canadian colleagues have told us, no, the SSRIs are not contraindicated in patients who have overproduction of serotonin. So the answer is no. How the problem with using SSRIs in carcinoid patients is the same as in any patient. They work for a while, they don't work, you have to rotate on and off, you have to work with a professional who uses SSRIs, and that professional has to be comfortable that when the systemic levels of serotonin are high, that the SSRI is not going to do anything to the tumor producing serotonin, and the chemistry in the brain is totally separate. There's a firewall between serotonin physiology in the brain and serotonin physiology outside the brain. So by taking an SSRI, that's going to be targeted to the brain. And you would almost think, and what proves this is that if you have elevated serotonin levels, you have your own SSRI built in. You would never get depressed. You would go around feeling great, euphoric all the time. But that's not the case, because that high level of serotonin does not get into the brain. So the question, so it sort of answers itself, the fact that we don't see, I'm convinced that we don't see an increased number of psychiatric disorders in our carcinoid patients. I don't think so. I don't think that's scientific. It's probably a belief. That's what I believe. When I look at my carcinoid patients, I don't sit and tell them, oh, you look like you're headed to manic depressive disorder. You know, I've never discussed that. Never discussed talking to them about, oh, you're at increased risk for suicide or manic depressive or anything that the psychiatrists have to deal with. So I don't think they exacerbate carcinoid syndrome. I don't think the SSRIs make it worse. I don't think it helps it. I don't think it makes it worse. I think it's neutral. So my advice there is give it a try. If it doesn't work, don't give up. Start off, be smart about it. Start off small, low doses, titrate gently. If it harms, stop it. The next question is, when a NETs patient has primary tumors in small intestine, is surgery more beneficial than risky, even if tumors have metastasis at both lobes of the liver? This one's yours. Okay, so I'll read it again. When a NETs patient has primary tumors in their small bowel, is surgery more beneficial than risky, even if the tumors have spread to both lobes of the liver? This is a great question. It's a debate that goes on.
As I said earlier, our mentality is once the tumor goes to the liver, it's stage 4 disease, and you really should not do much about it. And the first slide I quoted is a Sweden study show you, if you just remove the primary, the patient's survival benefit. And Rob Palmier showed the same thing, and the 2 other studies I showed you from England and Italy both show the same thing. So in other words, by remove the primary, patient benefit from it. But not everyone can go on surgery. So, you need to make sure the patient is healthy enough and patient have enough nutrition to heal the wound. So because the surgery is effective in helping those patients, but you can do the best surgery if you don't have healing power. The surgery is not going to help you. So to make the question short, to answer the short way is, if the healthy patient who is a good performance status, remove the primary is always a good thing to do. And as a matter of fact, we have seen about 40% of patients, when you remove the primary, the liver metastasis start to shrink a little bit. And so almost there's some direct signal that bin Laden is sending out to his disciples in the distance. And once you knock out the primary tumor, the cell abroad behave a little bit better. This is just is the same question. That's a removal of the primary affect prognosis. To me, disease, as the pyramid I show you, the carcinoid is, start from somewhere. There's small primary, but the small primary can then send out all this metastasis to the lymph node and to the liver. So if you knock off the primary, maybe that will stop the process from going on, had a further dissemination from the primary. So I always think, if someone's healthy enough, I really like to remove the primary. The sequence is when you do that first, or you can control the liver disease first or something, that's become a debatable issue.
What is considered a dangerously high level of 5-HIA? So there's not a real specific number, so it's going to be a range. When it gets 4 or 5 times the upper limit, those are times that we really want to make sure it's not going even further, higher. When it's 2 to 3 times upper limit, that's not uncommon. What's considered to be the best way of controlling the serotonin levels. Surgery obviously would be the best if it could all be removed surgically. Somatostatin analogs to suppress it, Talotrostat to block the synthesis. So you can see that when Talotrostat was developed, it was developed in patients already on the somatostatin analogs. So for maximum control in the metastatic setting, we would suppress the release with octreotide or lanreotide, and we would inhibit the synthesis with Talotrostat. Why do chromogranin levels go up and down sporadically? So what happens in the body physiology is these vesicles that store serotonin fuse with their plasma membrane and secrete it. Chromogranin just comes out with that secretion. So there's no other way that it gets out in the blood. It's a packaging protein. It's best to think of chromogranin sort of like the peanuts that in a package that's sent. These peanuts are added to protect the contents, and chromogranin is kind of like it's there as the real function of it and things is not really well defined. There's 4 or 5 different kinds of chromogranin, but we can see that it's going to be secreted along the way. So chromogranin doesn't correlate with carcinoid heart disease. Chromogranin goes up if you're on a PPI. It goes up because we blocked acid, and what's the body trying to do is trying to make acid. So to try to make acid, it's making gastrin. In order to make gastrin, it has to secrete gastrin from these vacuoles. What happens when the body tries to secrete gastrin? Chromogranin goes along because it's a packaging part of that vacuole. So chromogranin goes up with chronic renal insufficiency. So it's nonspecific. Hopefully that's okay. Has medical marijuana or CBD been deemed helpful for treating NET cancer? The answer to that is no. Is there any evidence on lanreotide use to delay, prevent tumor recurrence? So these somatostatin analogs have been shown to delay tumor, but the setting of recurrence is no, because that trial would take probably 20 or 30 years to do, or maybe longer. And it's not practical to do surgery on people and then half of them put them on analogs, half of them not put on analogs, and then wait 20 or 30 years. That's basically what you'd be doing. Do you have any other comments on that? Yeah. Do you ever use lanreotide, octreotide after you've operated on somebody and they have no evidence of disease?
Yeah, as a matter of fact, when I was a speaker at the Santa Fe 2012, and one of the audience asked me, would you, put put someone on hormonal therapy after successful surgery. At that time, I without thinking, I said, yes, I will. And then, so one of the German surgeons stood up and said, what are you treating? I say, I'm preventing microscopic disease from coming back. And the German surgeon making fun of me, he said, you are treating yourself, not treating patient. If you don't have disease, what you really should not do that. And the European surgeons and or the medical oncologist view is you save the money for the rainy days. You only restart the patient on the hormonal therapy when you have evidence of disease. And you don't have evidence of disease, you should not use it. Because if you put someone on lanreotide or triotide constantly, with time, the drug becomes less effective. When the disease really comes back, it's no longer working too well.
How does concurrent diseases such as diabetes affect treatment, and specifically wound management? So from our perspective on the medical side, when we use the hormonal agents, lanreotide, octreotide, it raises blood sugar. So we have to adjust the hypoglycemic agents. When we use everolimus, the mTOR inhibitor, that raises blood sugar. We have to adjust the diabetes medicine. So these are common side effects. We can deal with them. In terms of wound management,
yeah, diabetes, as well, it's one of the major problems for surgery in general as well. There's many studies, especially the best studies come from cardiothoracic surgeon. When you have a sugar not controlled, the chance of the wound infection of the sternal wounds, when you open the heart surgery, the wound don't heal too well. So we do try to get the diabetes the best control possible before we do any surgery. It's just a general rule, not just for the carcinoid.
Is it advised to ever stop monthly injections of sandostatin/octreotide? So yes, we do stop them. We stop them in cases that we feel like they're not improving symptoms. That's one of the first things we put patients on it. We stop it if the disease is progressing. So really there's sort of two indications for using somatostatin analogs, tumor symptom control and tumor control. What is the result of stopping? Generally, it's very individual. Some patients that I've stopped never go back on. Some patients go back on within 3 months or longer. Usually someone who undergoes surgery, we've taken out a lot of their disease. We want to see if they're going to be symptomatic afterwards, and that would be the situation, another situation we might stop. But anytime we think the drug is not contributing, we need to stop it and rest and see if it's really necessary. Other than the 5-HI urine test, what's the best test for serotonin? Well, a blood test for serotonin. So getting a blood serotonin level can help because 220 is the normal concentration of serotonin. So if 220 is normal, when we start getting numbers that are above 500, then that would be 2.5 times. We start getting a little bit interested, and this may become more of a problem. But when they get over 1,000, when they're 5 times elevated, serotonin levels every time we measure it is over 1,000. That tells us that person's being exposed to significant levels. So a single number for serotonin doesn't help us a lot, but the range it's in, if it's 3 times, 5 times, consistently in that range. So the next is a blood test for 5-HI. There's a test that can be ordered. The tubes, there are enzymes that go in the tubes to stabilize the enzymes for degradation. That tube costs about $100, and it only is good for like 3 months. So when you go into an office, they're not going to store these $100 tubes ready for you. And so we obviously are drawing 5 to 10 every day. So for us it's not an issue, but it's a big issue in small centers that do not want to, that can't, it's not practical for them to be buying these expensive tubes that are going to expire. They're more likely not to use them than to use them. So there's pluses and minuses. There's in England. There they have developed an HPLC assay. They've developed a mass spec assay, mass spec for 5-HIA. There they don't need those stabilizing enzymes. So just the way they do it in England. Okay, so that's kind of the world we live in. What's the success rate after getting 4 treatments of PRRT? The success rate is there's an 80% chance that you're going to benefit. And so what does that benefit mean? It means you have an improved quality of life. It means that there's going to be a delay of progression. The delay of progression is going to be 40+ months. The survival curves look like they're going to be significantly different between the high-dose octreotide and the PRRT treatments. So, so it's going to mean that you're going to live longer, better by years. What is the best treatment for NET G2? So there, it depends on if it's stage 4 metastatic disease. Typically, that we might use oral chemotherapy, capecitabine, oral form of 5-FU with temozolomide. Then we would consider everolimus, and we might consider the sunitinib. We might consider we might consider local regional therapies. We can consider PRRT. So there's a lot of things for treatment, and I didn't mention the somatostatin analog. So it's most everything that we do, surgery included, for NET G2. The primary site's in the duodenum. We would try to maybe manage that primary site by surgery if possible, if it makes sense. Secondary sites in the liver, then we would basically be looking at local regional therapy for that for tumor control. Whoever wrote that question probably ought to see me in the aftermath, because this is what I do for a living, is I reduce diseases in the liver non-surgically. Is NET a hereditary disease? Yes, there is a NET form of hereditary disease. It's called MEN1, multiple endocrine neoplasia type 1. It's where people commonly might show up in the ER. Well, first of all, they have a family history. But when it presents sporadically, and it's also, the MEN1 can be sporadic, people show up with kidney stones. Kidney stones, they have a problem with calcium, hyperparathyroidism, then it traces back to for pituitary. So it's pituitary, hyperparathyroids in the neck, and then pancreatic neuroendocrine tumor. So that's the hereditary form. That's why it's called multiple endocrine neoplasia, because it's pancreas and pituitary and parathyroid, the 3 Ps. Size of the, let's see, is there a true limit for 5-HI chromogranin in blood work? A true limit? I've seen several different high-level cutoffs. So what 5-HI cutoffs always single digit, up to 10 usually. Chromogranin A will be dependent on which antibody, which lab does it. So that can vary. I've seen it less than 5. I've seen it, ours is 93 in the lab that we use. I've seen several different high levels. See, does it vary from medical? So it does. It varies from what lab you use, not necessarily the medical center. I'd like to thank Dr. Wang for not stopping but moving forward in his surgeries. We need more doctors like that. Thank you for the lives you have saved. Maybe a big clap.
Thank you.
If Merkel cell cancer is sensitive to immunotherapy, will it work on our kinds of tumor? So Merkel cell being high proliferative is a little different. We're working on making these cold tumors hot, so it's research. We've seen some of these, there's studies now that bronchial carcinoids, about a third of them, the numbers are small that's done this, but about a third of them may respond. So there's hope. It's moving along. For the gut, pancreas, and intestinal, it's more in the below 10% is the data to date that's been done in clinical trials. Does hormonal replacement therapy for menopause cause these tumors to grow? No. Not been proven. Is the 5-HI test for PNETs as well? No. 5-HI is for small bowel. So serotonin is not connected to pancreas. So when we think of pancreas, this is Steve Jobs' disease. This is Steve Jobs. This is hormones that are peptides. So we think of intestines, we think of small molecule amino acid hormones, serotonin. When we think of the pancreas, we think of the insulin. That's what the pancreas does. Glucagon, gastrin, VIP, somatostatin, modulin, a whole different biology. The cells, the beta cells in the pancreas make peptides, not serotonin. So when we see PNETs, we think of chromogranin being elevated again. Everything else goes up with chromogranin, not specific. Serotonin is specific to lung, more gut is where we see it. So I don't waste my time measuring serotonin in PNETs. It's a waste of time. If there is elevated in PNETs, I think of, well, maybe they got the diagnosis wrong. Maybe this is intestinal. And I've seen that too, mistake. It looks like it's a lymph node right next to the pancreas. And it looks like it's in the pancreas, but it's really a met from a small bowel and the elevated. So you have to be real careful when you start talking about serotonin being a problem in an organ that normally makes peptides. Can PNET have carcinoma symptoms? So the PNET symptoms would be those symptoms that hormone would be up. So it would be an insulinoma because your blood sugars are low. My patient that only had symptoms Sunday morning, that's a PNET symptom. Not carcinoma syndrome, but insulinoma syndrome, hypoglycemia. Diabetes with glucagon being elevated. Any new onset, sudden onset of diabetes in a tumor in the pancreas, those have to be connected, get a glucagon level and see if they're connected. Somebody with severe diarrhea, then we have to look at vasoactive intestinal peptide and gastrin as mediators of severe diarrhea. It's not carcinoma diarrhea. It's VIPoma, it's a VIPoma, or gastrinoma. I swear I don't feel good with dental work is epinephrine. So epinephrine is local. It certainly could cause a flush. It has to be discussed with the dentist beforehand. If you're on blockers, you could take octreotide sub-Q before a procedure and treat yourself. For postmenopausal women, is it safe to take hormonal replacement therapy? I think we said yes. Does it cause an increase in growth? We don't think so. Dr. Wang mentioned a new scan for approval, questionable. Okay, I think what he's talking about is copper 64. Yeah.
Yeah, we talk about it, copper 64. To me, from my perspective, I'm the first one to use arterial scan to find tumor. Use handheld Geiger counter that I show you. I can go in and find a tumor in the mediastinum without opening the chest. But the problem with arterial scan is only 75% sensitivity. So I miss about 25% of patients who has a disease, but I cannot depict the disease by the arterial scan. In other words, those patients, the 25% of patients, I cannot use that technology to take them back to the operating room. The gallium-68 is very sensitive to pick up about 96% of patients. However, the gallium-68, the half-life of only 2 hours. So in other words, after you inject into the human's body, in 2 hours, they only have a 50% of energy left. And then in another 2 hours, only have a 25% energy left. By the time I get injection, get the scan done, take them back to the operating room, put them sleep, open up, all the energy is gone. I cannot use handheld Geiger counter to find tumor. However, the copper 64, the half-life is 12.7 hours. So I have enough time to inject them, get a scan, take them to the operating room, put them to sleep, and use the handheld Geiger counter to find the tumor. So that's what I'm talking about, and I'm hoping that will become a technology we can use pretty soon.
So this is a very important understanding of the difference between staging and grading. So I talked about grades 1, 2, and 3. That's the pathologist. Whenever you hear the word grade, the pathologist is talking to you. That's the pathology. When you hear the word stage, that's your surgeon or your medical oncologist or your radiation oncologist, whoever you're seeing managing your case, not the pathologist. Pathologist does not stage a patient. You know why? They only are looking at what's under their microscope. They're not looking at the scans. They're not looking at the patient. So your doctor it's hard, pathologists are doctors, so I don't want to say your doctor, because the pathologist is your doctor too. You just never see him. You better not. They don't like patients showing up in their offices. I've had it happen. So your stage is where the tumor's located. If it's just located in one spot where it formed, the early stage, cured at stage 1. If it's regional, if it's spread just maybe through the bowel wall, stage 2. If it's in just lymph nodes, regional lymph nodes, we call that local regional, stage 3. If it's spread to bone, distant lymph nodes, or liver, stage 4. Hopefully everybody understands that. That's a key understanding, because you can have grade 3, stage 1, grade 3, stage 4, grade 2, stage 1, grade 2, stage 3, any combination could go in there. Can the growth rate change Ki-67 after years of lanreotide? You want to take that one? And I'm going to sort of look, Dr. Wang, when he operates and sends specimens from metastatic sites as well as the primary sites. And he operates on people who have had the disease at the very beginning, and then at times when they've been on lanreotide or octreotide for years. Any thoughts there in terms of, does the biology, when we treat, do we change the biology over time?
Yeah, one thing is I will tell patient, not any patient, just a similar, biology and pathology. So some people you put on standard, disease may be stable for the next 25 years. Some people you put on the lanreotide, in 5 years the disease progresses. Some people may progress in 3 months. So everyone is different. So in other words, this is a spectrum of disease, not just one single entity. Never we have a patient behave the same way.
So getting back to MEN1, should family members be tested? So our recommendation for genetic testing is if MEN1 is present, now that we do measure the mutations, we detect this now in people. We're doing whole exome sequencing now on a common basis, so we can find it out. We generally, if there's one or more close family members, so you have the patient, then one or more family members. So you need about 3 to really show that there is a familial component to it. So family members, you got to be real gentle with some of that. It's not. I would never want to approach and say mandatory. I think it's something that would have to make sense for the time. So that's we actually have geneticists that actually they're professionals in doing it. So that's what my comments to that question would have. See a genetic counselor and have it explained to you by them. Do animals get nets? And the answer is yes. I've actually been a speaker at a veterinary society meeting, and is actually the group in Indiana, Purdue, actually has done quite a bit of this work. Purdue University has got some veterinarians that've seen it in their animals. They've published on this.
Yeah, there's a couple questions about the peanuts. Just if you thought about peanuts. As a matter of greater majority of peanuts are maybe non-functioning, so they may not have producing insulin or glucagon or those things or gastrin to give it.
Most of them.
Yeah. And so you do have to pay attention to that. The other thing is if someone with a multiple, primary in the pancreas, and if they have a kidney stone or those kind of things, those patients should be considered potential MEN1 disease, because those are the patients may have what we call 3P disease, parathyroid, pituitary, and pancreas. And usually those are pancreas and multiple tumors. And I found in Dallas, only 18 months I picked up about a patient from that. And a patient was lingering around with a kidney stone, with a tumor in the pancreas. No one put the 2 and 2 together. So I pick up those 8 patients when they have a multiple tumor in the pancreas with a kidney stone. I say something maybe going on. I work them up. For sure they have parathyroid disease too. And those patients should be treated, because otherwise they're going to get in trouble just with the pancreas disease alone.
Next question, are tumors homogeneous? If not, what is the value of a single Ki-67 index count? So we're always a bit suspect when we look at Ki-67 index. We have to match it up and make sure it matches the biology of that particular patient. So it's only, I would say, one element in the equation. Every time we scan someone, we're looking for that heterogeneity, hoping for homogeneity. We're constantly on the lookout for heterogeneity. And we see it. We see one area that one tumor is so not behaving like the other ones, and that's incongruous effect, incongruous, where one is not, progression in one, all the other ones are stable. So we can't biopsy all those other places. We can't do that to people. So we scan. So this is sort of where we're concerned, if you do have a low grade, does neuroendocrine tumors ever get to high grade, how high grade it is. So this is where we would use FDG scanning, the sugar scan, that would tell us high grade. The somatostatin scan tells us more lower grade, grades 1 and 2. So we can use scanning a little bit rather than go out and try to biopsy every little place. Okay, this is a question. Please talk about the NET test. Some people love it, some people hate it. Can you please give an unbiased review? So you'll get two of our opinions here. So our colleagues, Irv Modlin and his group at Yale, have developed this NET test. The NET test is still sort of local to them. We're testing it. We're trying to test it in some of our clinical protocols. So we're open-minded to it. We want to see how it performs in a research setting. I don't use it in my clinical practice because when you study it, the NET test, Dr. Modlin says I can predict what's going to happen, bad actors, good actors, or whatever. I can do that already with my scans and with the pathology, with everything I've got. I can't, if you do a NET test, say, well, you're going to be dead in 3 years. I don't really want to tell my patient that. So I don't find it very helpful to sit there and say your disease is going to progress in 3 years. Well, I know it's going to progress, but I don't know if it's going to be 3 years or 5 years or whatever. But I don't want to get real specific in knowing, because I can tell you the minute I tell somebody your tumor is going to progress in 3 years, I'll be wrong. Either progress in 3 months or progress in 30 years. Whatever I say, I will get it wrong. Okay, so I'm open-minded to it. It requires more testing. I've not found it to be useful in a non-research setting. And I hope Dr. Modlin provides us information that will guide us down the road. But just to tell me my patient's going to progress in a year or two or whatever, I don't really want to know that, to be honest with you. I can tell that already from what the faces I am. So you'd have to come into our algorithm. We take patients that we think of, if there's a risk of progression, we want to decrease that risk on the front end. We don't want to wait for progression if we think progression is going to be harmful. So we've already got progression built into our algorithms and our equations. Take it.
Yeah, I kind of skeptical about this too. There's just, some other stuff we look at, the KI67, the disease progression, the rate of progression before they come to me. So I don't necessarily have to buy into it, but I'm also open-minded. As I said, if you don't have a new, fresh thought, you will never get some new place.
Markers are the commonly used markers, chromogram 5HA, great, fair, or non-terrific. So in the right patient, they're terrific. In the wrong patient, they're terrible. So when someone comes in, they have disease, we use it for diagnosis, so that's one aspect of it. And then how do we use it for follow-up? Can it give us an early indicator of progression? Or as the question with lanreotide, octreotide, when you've been operated on, you don't have any disease, and you're following chromogranin, and the chromogranin starts going up, do you start lanreotide in people who are at risk because the chromogranin is going up? I've not met one NET specialist that makes a decision on chromogranin alone, not one. So that tells you chromogranin is not terrific. So in many respects, I almost don't like getting chromogranin because it's confusing, very confusing. 5HI, on the other hand, is very specific. Very specific. And once we know that it's a useful marker, it guides us in decision making. Let's see, anesthesiologists. Do you choose your anesthesiologist, or are they assigned by the hospital? How important are they?
This is a very good question. As a matter of fact, one of the things it can happen is when you put patient to sleep, or when you're doing surgery, you manipulate tumor, and you can make a massive release of the hormone from the tumor come out and causing a crisis. And people can really die in the operating room. And I tell you that the scariest experience I had myself. I had a patient one day going to crisis, the heart rate go down to 46, the blood pressure, and go down to 40s. And will have anyone crap in the operating room. We were all terrified, especially the few patients. And the first few patients, when the carcinoma crisis happened, we have to stop everything. We just kind of reverse everything, stop the anesthetic, and bring the patient out, and we did not even finish surgery. But with time, we finally start to recognize that there's maybe a way you can prevent from it. It's not perfect, but it can be prevented. So when I went to Baylor, I spent 3 months to teach the hospital staff, ICU staff, anesthesiology staff, how to prevent this from happening. So one of the studies which we did is one with New Orleans, we give patient enough sandostatin and to see how much sandostatin can saturate the tumor receptor in the human body. At that time, our study showed if you give someone with a 2 milligram of sandostatin IV push at one time as a bolus, you can saturate all the tumor receptor. Almost you make the tumor drunk, so you can manipulate it, do anything, they don't react. So this is what we developed a protocol. I use 500 microgram of sandostatin bolus, push in right away, and then I let the patient stay on the drip for 90 minutes at 500 microgram an hour drip. So by 90 minutes with the bolus, I literally load my patient 2 milligrams of sandostatin before I take them back to the operating room to induce to do surgery. With that protocol, with LSU's experience, we got carcinoma crisis to 3%. Average carcinoma crisis happen in the operating room throughout the country is about 25 to 30%. So it's a very important thing. If you go to anywhere for surgery, do make sure the anesthesiologists know what the carcinoma crisis is, how to prevent it, how to treat it. Once it happens, then you have to give sandostatin bolus very quickly, then you have to give calcium very quickly, and sometimes you have to give bicarb.
Do metastases metastasize? If not, why the emphasis on finding the primary? Great question. Do metastases metastasize? Yes. That's the general principle in oncology. If you've got metastatic disease, you're at risk for having other metastatic sites, but you'll never know, never know whether one metastasis created another metastasis. This is biology that is too complex to really decide, to determine. But if you've got one metastatic site in your body, then we would treat that specifically as a solitary. We would treat it as if it was the only site, but that person would be watched very carefully for other metastatic sites, because what we don't know is before you remove a primary, how many metastases were there before you did that, and it just took time for that to occur. So it's a complex question. And the emphasis on finding the primary. The primary is important for us because at our current level of knowledge, we know the natural history of different primaries. So it's important for us to know, say, if it's intestinal primary, we can predict what's going to happen with that one. If it's a pancreatic primary, then we know that biology is a little different as well, natural history. So it also helps us when we try to get drugs approved. If I can label someone as a small bowel, then that would get, let's say, PRRT approved. If I label them as bronchial, it may not get approved. We've gotten them approved, but it's not in the package insert, it's off-label. So if you look at the use of Sutent for pancreas, that's not indicated for small bowel. So that is specific for, so some drugs do make a difference. So the other part is if we know it's intestinal primary, maybe by the gene testing, then we might be working with that person to say you might be at some risk for small bowel obstruction at some future time. Do you have any comments on metastases, metastasize? Any other comments on that? Okay. Are there any true NET specialists on the east coast of Florida? Any true NET specialists on the east coast of Florida? Well, you're pretty close to the west coast, so east coast, west coast, you're not a real fat state. Oh, I say, yeah, and I'd go up to Jacksonville, Mayo. Yeah.
Fort Lauderdale, that carcinoma.org site, go in there and type in your state.
Yeah. Well, work with Peter Hussein at University of Miami. Peter.
Working with Peter.
Yeah.
And if you need a surgeon, Dr.
Yeah.
You guys know Cesar Goulet?
He was
Yes,
trained by
yes,
me.
we know Cesar, yeah, Cesar, yeah, trained at LSU.
He's our surgeon.
Uh,
Peter Hussein is down at,
University of Miami. Yeah, Sylvester. Yeah. Should you refrain from taking SSRIs and birth control pills? No. Can you still have symptoms, for instance, increased heart rate, diarrhea after the tumor's removed? Well, yeah, you could. The symptoms may be different mechanism, depends on which disease is left behind. So that's a little bit of a complex question. Can you resume eating, drinking foods that were advised to avoid after the tumors were removed? Yes, absolutely. So the rule on eating, drinking is don't eat or drink anything that will eat you. So if something's is harmful to you, don't eat it. So, but what I think the question is is there any foods that you would want to avoid potentially, or can you resume eating or drinking foods that were advised to avoid after the tumors were removed? So the only times we restrict diet is maybe during the 5-HI urine collection, and Leanne will address that a lot this afternoon.
You also remember that the tumor in the small intestine, initially, even they release a hormone, they can never hurt you because the liver will break down all this product. So usually when people become symptomatic, they tell you one thing is they must have disease, go to the liver already, and the tumor from the liver metastasis release serotonin. Those serotonin cannot be broken down by the liver itself, or they have the lymph node go to retroperitoneum. So if someone with a surgery or something, say removed primary, they still have symptom, most likely surgeon missed something in the liver or miss something in the retroperitoneal lymph nodes.
How likely is it to find the primary net in its beginning? Most of the time, probably about 10% are probably unknown primary. And if it is found and removed, is it true nets will not come back? Okay, so what's important in any surgery is the stage. So when you're surgically staged, we can tell and predict what the risk is of recurrence. And that's related to lymph node involvement, as well as whether that tumor has invaded the nerves or the vasculature, the lymphatics, and the lymph nodes. So, and also the grade. If it's a high-grade neuroendocrine tumor that's invaded lymph nodes, we know that's going to come back 9 times out of 10, maybe 99 times out of 100. If it's a low-grade tumor that's invaded 0 lymph nodes and 25 were taken, you always have to understand what the denominator is. That patient probably is cured, So the more lymph nodes that are involved, the more likely the tumor is going to come back. So that's sort of, if you've got anything, so it's all related to stage.
And we see this, patient got diagnosed in so-called retrograde fashion a lot. The patient with something by scanning, pick it up by accident, something in the liver, like a whole bunch of lumps. They biopsy the liver, they show neuroendocrine tumor, and no one knows where the primary is. In those patients, we work them out by the tumor markers, by the scanning, and sometimes you still cannot see it. And I wrote a paper on this called Unknown Primary. We operate on the 46 patient, we just unknown primary, but we go in the operating room and we find it, and almost like 98% of the time we will find the primary. When someone has enough experience, they know where to find it. And based on the tumor biology, biopsy, there's one other way they can do called diagnostic. You can biopsy and then they can do a prediction, say more likely where the tumor coming from. And that test is $3,000. I told the patient, don't even waste that $3,000. If you find a good surgeon, they know where to find the tumor.
How does the use of anesthesia for other procedures impact a pancreatic net tumor?
The pancreas, as Dr. Anthony alluded, they usually don't produce the serotonin in the high quantity, so to cause a crisis. So the PNETs usually is not a big threat. For the small bowel nets, especially the high serotonin producing tumor, any procedure can trigger into crisis because there's sudden release. So those patients should consult with anyone. You do a breast augmentation, you have a big dental procedure, breast implant or something. You do have to have your doctor talk to the net specialist and a special surgeon to how to prevent carcinoma crisis from happening. Should that happen, how do you treat it?
Are there contraindications to taking SSRIs such as Lexapro with neuroendocrine tumors? Our Canadian colleagues would say no. Tips to find local doctor to manage care. Any advice for lung carcinoids? So the best way, I think, if you're navigating through your own healthcare system, is try to find somebody who's interested in you, somebody that maybe listens to you, and if not, maybe you let them refer you on potentially if they're uncomfortable. But what's really mandatory is to have somebody local that you like, you get along with, they like you. When I say like, I'm saying take an interest in, like they'll embrace you as a patient and they listen and they want to help you instead of, you know what I'm talking about. It's probably body language, a lot of things that go on in that relationship. So I would say that let that physician refer on, let that physician work as a team locally to go to a net center specialist. And what I generally find helpful is if patients are seen at least once, if their cases can be reviewed at least once in a center of excellence, then recommendations can go back. And then the patient would only have to return to that center if other issues came up in the care of that patient. So I think it's important that an opinion and a care plan get created by a group that's used to dealing with the nuances of that disease and not assume that, I can read all about it. We can, I've worked with, patients will be self-referred to me. They'll come through and when the self-refer, I always have to ask them, I need to work with somebody locally. Who can I work with? And they'll tell me real quick that my oncologist doesn't want to work with anybody. They think they can do it all locally. There's no, and then, I kind of realize that probably not going to work out for me to send my letters recommendation back to that person. And there you have to sort of not, attempt to, what I do is find that person, another oncologist in that community. So being in the 300-mile area of Lexington, I pretty well know anybody that will work with me, and I can direct those patients accordingly to the medical oncology for their depot formulations if that's what it requires. How do you determine if the pituitary tumor is causing the serotonin levels high? So a pituitary tumor is going to be secreting, for the most part, growth hormone. So the pituitary tumor, it can secrete all the other hormones, prolactin and MSH and other hormones that the pituitary makes, but LHRH. But the driver, pituitary is not going to drive the serotonin as such. You could think of growth hormone being stimulatory to cells, and that being such that it could make these cells live on and things. But growth hormone is sort of in the world of endocrinology, and it doesn't really cross into the world of carcinoid and PNETs. Obviously there can be tumors that we see that could make growth hormone or stuff, but the pituitary is pretty much, it's an adenoma in 99.9% of the time. It's not a malignancy. So pituitary adenomas are the ones that grow in the sella turcica that causes headaches and visual disturbances and things that have to be dealt with, ACTH problems and things. Can anti-diarrheal drugs help control diarrhea and carcinoid syndrome? Absolutely, no question about it. We always use them first. Talk about following chromogranin versus 5-HIA. So chromogranin A becomes the generic biomarker for any neuroendocrine tumor. It could be for a pheochromocytoma. It could be for a paraganglioma, for a PNET, for a bronchial carcinoid, for an intestinal carcinoid. So it becomes the universal biomarker. But in the context, we know that PPIs, the proton pump inhibitors taken by many people for GERD symptoms, GI symptoms, raises the levels of chromogranin. So we have to be very, very careful when we look at it because it's non-specific for any one tumor type. 5-HI is very specific to the intestinal subtype or a bronchial subtype. So most of them are intestinal, very specific. So we don't see other tumors making that usually. After surgery on my small intestine, I was told I have tons of tumors in my mesentery. I was told surgery, chemo, and radiation are not options for tumors of the mesentery. Any other options?
As I said, it's all case by case. In general, if you can have someone do all this in one setting, that's ideally. And that's what my philosophy is. If someone come to me have not been operated yet, when I go in there, I always joke with the patient. I say, you get the best cleaning lady to clean your house. I will mop your floor at the same time. So I will remove the primary, get all the lymph node out. I will scan the liver and dig out all the tumor in the liver, or I barbecue the liver, use microwave energy. However, if the primary surgery is done and now you are in the recovery phase, I have to consider scar tissue, how your nutritional status, how much surgeon has removed, and those kind of things. Then I take it case by case. If you tell me, say, you have disease progression very bad, by the scan confirm it, and you have a serotonin production, you have massive diarrhea. On the other hand, I can see scan on your liver, you have big dominant tumor mass. Those patients, I do recommend to go back. I do surgery, just remove the tumor and reduce the serotonin production. Your quality of life improves dramatically. On the other hand, if you show the small BBs everywhere, I will send you to Dr. Anthony, let him put on afinitor and chemoembolization later on to control your symptoms that way. So just really not one size fits all. It's really case by case. You need to find a good physician who know what to do. Plus, all the neuroendocrine tumor centers have different philosophy, different approach. If you come to me, for instance, just likely I will recommend surgery because that's what I do. I'm more into surgery. If you got referred to University of Pennsylvania, they most likely refer you to IR because that group, the most dominant is by intervention radiologists. Most of the procedure they do by intervention radiologists. So if you go somewhere else, they may, say let's the medical therapy first because that's they're most experienced with. So that's why a lot of good advice is always to see some next specialist, also know what their specialty is, what their major interest is, and what the institution philosophy is too.
Dr. Wang, how long should a patient wait if the disease is stable and they have no symptoms, but they're operable? The primary has already been removed, and now somatostatin analogs for further surgery. Should you operate now or later?
Yeah, I just answered that question. I say it's all case by case, depending on patient. If a young, healthy patient, if the disease can be removed all in one setting, and maybe such something to do is worthwhile. On the other hand, the surgery is also the most risky procedure, right? Even in my hand, I can still have a 2% mortality, when I do a very big complicated cases. So you have to take a look into the account. On the other hand, if the disease is located in the root of mesentery, the lymphatic is choking on the blood supply to the intestine or choking the blood supply to the liver, and patients start to have a liver dysfunction or show signs of intestinal ischemia when you eat food, 30 minutes after you eat food here, all the cramp, all the pain in the abdomen, because the blood supply go to intestine, try to help digestion, cannot come in because the blockage of the lymph node to the vessel. Those patients maybe, the surgery should be done early before it's too late.
Well differentiated grade 1, low-grade carcinoid, 3 tumors, 7 centimeter, the largest, 1 lymph node involved, tested 12, what stage?
I think time is all the rest of the question. If someone wrote this question, did not get answered, come to see me or see Dr. Anthony.
I think it'd be a stage 3A, be an early stage 3. Real quick, Xolair was asked for antihistamine for carcinoma syndrome. Yes, I'm familiar with Xolair. Xolair is an injectable monoclonal that is given to inhibit IgE from binding to mast cells. Yes, it's helpful. Using it in carcinoma syndrome is fine if it helps. But it's not one of the drugs that we commonly use. Okay, I guess we should take a break.
Yeah, whoever the question was not answered, either approach me or
There's a
approach
diabetic question right there.
and Dr. Anthony will answer that. Okay, thank you.